Picture this. You're diving in some incredibly remote spot, miles from anywhere, and someone surfaces with pretty clear signs of decompression sickness.
Yeah.
And the nearest chamber, it could be a day, maybe even more, away.
It's a tough scenario.
Yeah.
Happens more than you might think.
It really brings us to this, well, sometimes pretty contentious topic. In-water recompression, IWR.
Right. And what's really interesting, I think, is that IWR isn't some, brand new emergency fix.
Oh, really?
No, its roots go way, way back. Before we even had recompression chambers, you had divers in the 19th century. If they felt pain after a dive, sometimes they'd get back in the water.
Just like that, intuitively.
Pretty much. Trying to find relief, maybe sort of unconsciously redoing their stops. It was the logical thing, maybe, in their minds back then.
Okay, so let's unpack this. The basic idea is trying to treat the DCS right there, on the spot, in the water. What's the science behind why that might actually work?
Well, the fundamental goal, whether it's a fancy hyperbaric chamber or just the ocean, is tackling those darn gas bubbles causing all the trouble.
Okay.
Pressure is your main tool. Increase the surrounding pressure and you physically shrink the bubbles. Simple physics, really.
Right. Squeeze them down.
Exactly. And at the same time, you want to help the body get rid of that excess inert gas, usually nitrogen, that's dissolved in the tissues and bubbles. And you want to flood the tissues with oxygen.
Ah, right. Breathing pure oxygen under pressure, that dramatically increases how much O2 gets into your system, doesn't it?
Spot on. Think about it like pressure pushing the oxygen in. At the surface, breathing air, the oxygen pressure in your lungs, the force driving it into your blood, it's, normal. But go down, say, 60 feet and breathe 100% oxygen. That pressure, that driving force, it skyrockets. We're talking maybe 20 times higher.
Wow.
Yeah. So you get this massive gradient pushing oxygen into the tissues. And that's super important, even if tiny bubbles are kind of blocking the small blood vessels.
That makes a lot of sense. So getting that pressure and high O2 concentration started fast seems critical.
Absolutely. The sources we looked at, particularly the chapters in hyperbaric medicine practice, they really hammer this point home. The sooner you start recompression, the better the chance of a full recovery.
Okay.
So when a proper chamber is just too far away or it'll take too long to get there, you're basically looking at a few first aid options. Surface oxygen, maybe a portable chamber if one's miraculously available.
Right.
And then there's in-water recompression, usually with oxygen.
Now, this is where it gets really interesting because I know there's been, well, a lot of debate about IWR over the years. It's not like there's just one way everyone agrees on, is it?
No, definitely not. Over the decades, different IWR tables, different methods have popped up, mostly out of necessity. People diving in these really remote places needed something. And all these different approaches, they're basically trying to balance the potential good, getting that pressure and oxygen quickly against the, let's face it, inherent risks of putting someone who's already sick back underwater.
So can you walk us through some of the main strategies people have tried?
Sure. So one of the early ones was the Australian IWR table, developed by the Royal Australian Navy back in the 60s.
Okay.
It's pretty conservative. Max depth was only 30 feet, about 9 meters. The diver would stay there for 30 to 90 minutes, breathing 100% O2 the whole time.
And the ascent.
Really slow, just 1 foot every 4 minutes. Then, back on the surface, they'd alternate breathing oxygen and air for a while. So very cautious, focused on safety, shallower depth, slow ascent.
Very controlled, yeah. Yeah. Then you mentioned the Clipperton tables. From that remote expedition, they sounded a bit more aggressive.
Yeah, they definitely pushed things further, mainly because they were just so incredibly isolated out there on Clipperton Atoll.
Right.
They had a couple of variations. One was 70 minutes at 30 feet on oxygen, with a faster ascent, about 3 feet per minute.
Okay.
The second variant was much more complex. Involved an initial drop to 100 feet using a rebreather, trying to keep the oxygen partial pressure steady around 1.4 ATA for about 20 minutes.
Wow, 100 feet.
Yeah, then a gradual ascent back to 30 feet, purging the rebreather, and then 70 minutes breathing pure oxygen, followed by that 3 feet per minute ascent. It needed a lot of oxygen breathing before and after, too. Really shows how far they felt they needed to go.
And then the Hawaiian table, that took a different tack again, right? Going to the depth of relief.
Exactly. The idea there was descend on air to the depth, where the diver felt symptoms ease up, plus another 30 feet, but no deeper than 165 feet initially. Spend 10 minutes there.
On air?
Initially, yes. Then ascend over 10 minutes to 30 feet for a long period breathing oxygen.
And Richard Pyle modified that.
He did. Pyle's modifications added decision points, like check after 10 minutes at 30 feet. If symptoms weren't gone, maybe descend again in 25-foot steps, potentially using air or nitrox down to maybe 125 feet max, do a quick self-check, then varying ascent times. And crucially, he added air or nitrox breaks, 5 minutes every 20 minutes, doing those deeper phases. Then a slow ascent on oxygen, maybe 3 feet per minute. Much more adaptive.
Okay, lots of variations. What about the U.S. Navy? They have their own tables, too.
They do. 2 main ones, 60 minutes at 30 feet or 90 minutes at 30 feet. Both use 100% oxygen, and they include step descents, stopping at 20 feet and 10 feet, still breathing oxygen. Interestingly, no air brakes in the Navy tables during the water phase, and they really stress needing surface oxygen immediately after getting out.
And then more recently, INTD developed one.
Yeah, back in 2013. Theirs starts with 10 minutes at 30 feet on pure O2, then up to 25 feet. They actually did incorporate air brakes and used a slow 1 foot per minute ascent.
So a common thread seems to be extended time breathing oxygen, often at depths pushing that 1.6 ATA oxygen partial pressure limit.
Absolutely. That's a key point. Almost all these historical tables involve pushing the PO2, sometimes significantly, beyond what's standard for recreational diving and for long periods. And that carries its own risks, primarily CNS oxygen toxicity. Plus, they're logistically complex.
Okay, so given all these different approaches and the known risks, where does the expert community stand now? What's the current thinking on when and how to actually do IWR?
Right, that's crucial. And thankfully, the hyperbaric medicine practice chapter dives into this, based on a big consensus meeting of diving medicine experts back in 2014.
A consensus statement.
Yeah. It's important to frame it correctly, though. It's a set of recommendations, guidelines, based on the best evidence they had and, frankly, expert opinion, where solid clinical trial data is just lacking for these emergency situations.
Sure, that makes sense.
But it was a big step. It basically acknowledged IWR as a legitimate first aid option, but only under very specific, carefully thought-out conditions.
Okay, so what did they agree on? What were the key takeaways?
Well, first, they reiterated the gold standard.
Yeah.
Definitive treatment for DCS is pressure plus high concentration oxygen. No surprise there.
Right.
They also stated pretty clearly that pressure and oxygen together are better than just surface oxygen alone.
Okay.
And here's the big one. They concluded that IWR is a viable first aid method. Sort of an intermediate step when getting to a chamber quickly just isn't going to happen.
That feels like a significant shift, given the historical reluctance sometimes. Why did they reach that conclusion?
A major factor was acknowledging that immediacy, getting that pressure and oxygen working fast, can be absolutely critical for the best outcome in certain divers.
Especially severe cases.
Exactly. For divers with rapid onset, severe symptoms, the ones who look like they might have a poor prognosis if treatment is delayed, the experts felt the advantage of immediate IWR could outweigh the inherent risks.
Okay.
But they were also very clear. IWR is almost never the complete treatment. Getting the diver evaluated by a diving doc afterwards is non-negotiable, absolutely essential.
Did the consensus also provide specific guidance on how to implement IWR if you decide to do it?
Yes, very specific recommendations came out of it. First, the injured diver must have a tender with them the whole time, no exceptions.
Makes sense.
Keeping the diver warm, maintaining thermal comfort is really important too.
Yep.
And they stress that IWR should only be considered for divers with symptoms known to be associated with poor outcomes if treatment is delayed. Serious stuff.
Right, not for just a minor skin bend or fatigue.
Precisely. And the breathing gas. As close to 100% oxygen as you can possibly get. The goal is a PO2 of at least 1.6 ATA, but the absolute minimum FiO2 should be 0.80, so 80% oxygen.
And they set a maximum depth, right? Even if you can't get 100% O2.
Yes, a crucial safety point.
Yeah.
The emergency response depth should not exceed 20 feet or 6 meters,
Well,
even if you're using less than 100% oxygen.
20 feet. Okay.
And the time at that depth, maximum 120 minutes total. Ideally, you'd aim to finish the IWR within 60 minutes after symptoms start getting better.
What about air brakes? Some of the older tables had them.
The consensus recommended against planned air brakes. The feeling was they add too much complexity to an already challenging situation. Better to keep it simpler.
And ascent rate?
Slow, about 1 foot per minute if possible. Very controlled.
What about emergencies during the IWR itself? Loss of consciousness, seizures?
They covered that. Either the tender or the diver can call off the procedure at any time. If the diver loses consciousness, rapid ascent straight away. If they have a seizure, but their regulator or full face mask stays in place, maybe they have a retention strap, you hold them at depth until the seizure stops, then ascend rapidly.
But if they lose the regulator?
Immediate ascent. Don't try to put it back in underwater. Get them to the surface, even if the seizure's ongoing. That ABC's airway, breathing, circulation.
Got it. What if symptoms come back during the slow ascent?
You can go back down to 20 feet, but only if the total time spent at 20 feet hasn't hit that 120-minute limit yet.
And once they're out?
They say out. No reentry, even if symptoms return later. Surface treatment and evaluation from then on.
Okay. What about activity in the water?
Gentle finning, mild activity is okay, even encouraged. Helps circulation.
And really severe cases like paralysis.
That requires real judgment. You have to weigh the benefit of quick IWR versus getting them evacuated immediately. Consulting a diving medical expert, if at all possible, is highly recommended in those cases.
Okay. And they mentioned combining the last few shallow stops.
Yeah, the last 5 feet or so, doing those 1-minute stops can be tricky with waves and logistics, so combining them might be practical.
So it sounds like these recommendations really try to standardize things and build in safety margins, but are there times when IWR is just absolutely off the table?
Yes, definitely. The consensus outlines several absolute contraindications, situations where the risks are just too high.
Like what?
Things like isolated hearing loss or vertigo. You need to rule out an ear barotrauma first, because recompressing that could make it worse.
Makes sense.
Any kind of airway problem, difficulty clearing stuff, coughing blood or froth, a collapsed lung, severe coughing fits they call the chokes, vomiting, all absolute no-goes.
Obviously, cardiac arrest.
Right. Resuscitation is the priority there. Also, extreme anxiety panic underwater is incredibly dangerous, and you can't sedate them.
Okay.
Moderate or severe hypothermia, they can't manage gear, circulation is poor, it messes with detecting O2 toxicity signs.
Yeah.
Any altered mental state where they can't control their own equipment. Breathing really fast, severe tachypnea.
What about losing consciousness soon after surfacing?
Yeah. LOC within about 15 minutes of surfacing is a strong sign of arterial gas embolism, or AGE. That's an absolute contraindication for IWR. You also need to check for shock or hemodynamic instability. Shock itself or needing CPR rules it out immediately.
That's a pretty clear list. Are there also relative contraindications, things that make you pause and think twice?
Yes. Vertigo, even if you think it is DCS, can be so debilitating underwater that IWR becomes super risky. You still need to rule out middle ear barotrauma too.
Okay.
Then there are logistical issues. Water too cold, seas too rough, not enough oxygen, untrained people, sharks, or other hazards around. Or maybe you're actually not that far from a chamber, the risk-benefit changes.
Right.
And finally, if the symptoms are really mild, or if they get significantly better just on surface oxygen, the extra risks of IWR might not be justified, but you still need to watch them closely, get expert advice, probably evacuate anyway.
So the bottom line is IWR is only for someone fully conscious, cooperative, with no obvious breathing problems.
That's the key principle, yes.
Okay. Beyond the medical side, just trying to do this in a remote place sounds like a logistical nightmare.
It absolutely can be. Ideally, you'd want pre-emergency informed consent. Maybe people watch a video, sign a waiver beforehand if IWR is even a possibility on a trip.
And practice.
Crucial. Teams need to drill this stuff regularly to stay proficient, and you need absolute control of the diver underwater. Tethering is mandatory to a downline or directly to the tender.
Okay.
The surface team needs to be ready for anything, any sudden worsening. And if conditions turn bad or you can't manage a foreseeable risk, you have to terminate the IWR.
What about keeping the breathing gas source secure? You mentioned seizures.
Huge point. The consensus strongly recommends using a regulator retention strap, an RRS. Helps keep the regulator in the mouth if a seizure happens.
What about full face masks?
They're kind of the traditional ideal if people are trained. Better airway protection, you can talk, some thermal benefit, but big buts. Lack of training is common, fit can be an issue, clearing them is harder, gas switching gets complicated, they're expensive.
So RRS is a good alternative if FFM isn't practical.
Yeah, it's seen as a viable alternative. Lower cost, less training needed, though obviously less airway protection than a full mask. There's some evidence from military dive incidents suggesting gag straps work, but improvising one isn't encouraged.
You mentioned the 1.6 ATA limit for PO2 minimizes seizure risk but doesn't eliminate it.
Right. It's about balancing risk. Normal divers have depth limits, buddies watching them. A sick diver during IWR should just be breathing, maybe gentle movement, no hard work below 20 feet, keep them warm, hydrated.
What if you just don't have enough oxygen for a full protocol?
Then it's activate EMS, get ready for evac, ACP. While waiting, if it's safe, you can immerse the diver, head out, give them the highest O2% you have, following the general time guidelines, until maybe 15 minutes before transport arrives. The idea is maybe immersion helps fluid shifts. Not proven, but a potential stopgap.
Okay.
And again, no magic IWR table is proven better than others. But going over 1.6 ATA-PO2, strongly discouraged. Risks just goes up too much. Set up a safe O2 environment too. No sparks. Secure tanks. Use oxygen-safe gear. Get permission from a conscious victim. For unconscious, EMS first, then O2, assess.
And practically ensuring they don't go below 20 feet.
Tethering is key. A line marked at 20 feet may be weighted at the bottom, clipped to a fixed line, maybe slightly overweight the diver with the tether to reduce movement and help the buddy if there's a seizure. If there's current from a boat, drifting might be better than anchoring. And always fix the tether to the boat, not the anchor line.
Right, direct connection. You also mentioned a database.
Yeah, there's a community effort to collect data on IWR cases. It's at ibum.org, uwr.html. They try to capture details: who referred, outcome, warmth, water temp, complications, protocol used, surface O2, symptom timeline, dive profile, demographics. Really valuable for learning more.
The chapter also included a case study, right? It sounded like it came directly from the group that formed the consensus.
It did. A perfect example, really. Highly experienced team, hyperbaric doc, retired Navy SAT diver NTD guy, local dive shop owner, NTD IWR instructor. All involved in the symposium where the consensus was hammered out, aiming to gather good evidence.
What happened?
The dive itself was fine, planned sawtooth profile, deco cleared on the computer. But 15 minutes after surfacing, one diver had trouble getting his dry suit off, complained of bad back pain, radiating, got up to an 8 out of 10.
Any other symptoms?
No other neurological signs initially. Logistically, they were 2 hours from a chamber, but conditions were good for IWR right there.
So they did it.
Yep. 22 minutes after the dive ended, he was back in the water at 10 feet with a tender breathing O2. By 27 minutes post-dive, the 3-person team was down at the consensus depth, 20 feet.
And the result?
Amazingly fast. Within 2 minutes at 20 feet, so only 31 minutes after surfacing originally, his pain was completely gone. 0 out of 10.
Wow.
They finished the full consensus protocol, that slow 1 foot per minute ascent, no symptoms came back, did a neuro check, consulted other experts, no chamber treatment needed.
Impressive.
Yeah, they even did a Doppler echo. 24 hours later, just minor residual bubbles, no PFO. It's a great example of a well-informed group following the latest guidelines, reporting a good outcome. Really supports the potential when done right.
Of course, not everyone has always been on board with IWR. What are the main arguments against it, historically or even now?
Well, a key one is that surface oxygen can resolve some DCS cases. If symptoms get better on surface O2 and a chamber isn't terribly far away, maybe the risks of putting someone back in the water aren't worth it.
Right.
The current consensus kind of acknowledges that, but says, look, if surface O2 doesn't work or a chamber is ages away, IWR might be needed to prevent worse injury. It's always a balance. There's no magic formula, right? IWR is just trying to get pressure and oxygen on the problem quickly.
So what are those specific risks people worry about?
The theoretical list is long. Risk of loading more nitrogen if you use air or nitrox. Risk of oxygen toxicity, seizures from tier O2. Risk of drowning, obviously. Risk to the tenders. Getting cold. Bad weather blowing up. Hard to assess the diver properly underwater. Lots of potential downsides.
You said there are theoretical points supporting it too.
Definitely. The big one is just the physics. Immediate pressure shrinks bubbles. Studies show even shallow recompression to 1.6 ATA on oxygen reduces venous bubbles more than surface oxygen alone. Plus, that high inspired oxygen pressure helps fight inflammation, gets oxygen to tissues that might be starved. There are even some pilot studies suggesting IWR reduces overall decompression stress, measured by bubbles. Promising, but early days on that research.
Okay, let's circle back to using air instead of oxygen. You said historically it was common, but now it's frowned upon.
Pretty much. While, yeah, lots of old success stories probably used air, we now know oxygen is the crucial drug for DCS. Breathing air underwater means breathing lots of nitrogen under pressure. That can actually make the nitrogen problem worse.
So loading more gas in while trying to get gas out.
Exactly.
Yeah.
The consensus specifically warns against the old U.S. Navy Air IWR protocol, puts you under about 5 atmospheres pressure, but the oxygen partial pressure is only like 1.0, same as surface O2, while loading tons of nitrogen. Bad combo.
Okay.
And the Navy Air Treatment Table 1A. Forget trying that in the water without oxygen. Logistics are insane, benefit is doubtful, risk is huge. Think about it. Chamber treatments using air instead of O2 had high failure rates. Why would in-water air be any better? The Navy hardly uses those air tables anymore for a reason. They often don't work well.
Right, so focus on oxygen delivery. What about rebreathers for that?
Rebreathers definitely have potential, especially for giving 100% O2 for a long time on the surface.
How so?
Efficiency. An AL80 tank might give you, say, 150 minutes of O2 on open circuit, on a rebreather, maybe 2,900 minutes. Huge difference for storage, transport, and remote places.
Does the sick diver need rebreather training for surface use?
Nope. Someone qualified just sets it up and monitors it. Using one during IWR is different, though.
Oh.
It massively cuts O2 use, which is great. But the diver must be trained on that specific unit. And you have to worry about the CO2 scrubber lasting long enough. Can the diver manage it underwater? It adds complexity.
Okay, back to the oxygen risks underwater. How should teams handle potential O2 toxicity?
Constant vigilance is key. CNS toxicity risk goes up with PO2 over 1.6 bar underwater. If the diver feels any symptoms besides a seizure, they tell the tender immediately.
Then what?
Maybe switch to air if possible and safe. Tender watches like a hawk for a seizure. But those warning signs, they're unreliable. Sometimes you get them, sometimes you don't before convulsion. Safest bet. If premonitory symptoms appear, abort the IWR.
How do you abort?
Control descent, maybe over a minute or two. Tender stays close. Get them out, surface O2, evaluate for chamber evacuation.
And if a seizure does happen underwater? We touched on this.
Yeah, recap. If FFM or regulator stays in, hold them at depth till it stops, then rapid ascent, remove from water, ABCs. If regulator is lost, immediate surface, even during the seizure, remove from water, ABCs.
Okay.
Once they're stable, breathing okay, conscious for 15 months, keep giving surface O2. Pulmonary O2 toxicity is less likely with these protocols, but may be a concern after a really long, heavy O2 dive before the hit. Chest pain, cough for signs, uncontrolled coughing, surface them. Air brakes might help, but consult an expert first.
So the IWR is done, diver is back on the boat or shore. What's next?
Keep them warm, hydrate, have them lie down, flat is good. And then transport to the nearest hyperbaric facility for evaluation by a diving dock. That's mandatory.
Oxygen during transport.
Yes, if practical. If symptoms resolve completely after maybe 3 hours on surface O2, you can alternate 1 hour O2, 1 hour air during a long transport.
And no more diving until cleared.
Absolutely obligatory. Monitor them constantly. And gather all the paperwork. Dive profile, IWR details, assessments, responses, medical history, first aid given. Give it all to the chamber staff.
And send copies to that database.
Highly recommended. Helps everyone learn.
This has been incredibly thorough. As we wrap up, what are the absolute must-remember points from this deep dive?
I think the big picture is DCS is complex, diagnosis needs care, understanding how it progresses is key. Quick, accurate diagnosis, lots of fluids, keeping the diver warm, and immediate high-flow oxygen. These are always crucial.
Right.
Then, IWR is a tool to consider in specific situations, knowing all those contraindications we talked about. It seems counterintuitive, putting someone sick back underwater, but sometimes it might be the best immediate step if a chamber is far off.
But it's not a replacement for a chamber.
Definitely not. And the risks underwater might be higher isolation, fewer resources if things go wrong, especially with O2 toxicity. Mild DCS probably doesn't warrant IWR's risks if a chamber is reachable, but severe DCS, delayed chamber treatment, has a poor prognosis. So the immediacy of IWR might justify the risk in the right person.
And the diver has to be part of the plan.
Totally. They need to be clear-headed enough, able to communicate, manage their airway. The expert consensus is that there's enough experience now to justify IWR sometimes if teams are trained and equipped. These recommendations are tools to help docs make the best call when a chamber isn't an option. Always weigh the consequences. Try to do more good than harm.
It really throws into sharp relief that tension between doing something now versus the potential risks, especially in these extreme environments. A real ethical tightrope sometimes.
That's exactly. And it highlights how these practices in remote medicine are constantly evolving. For anyone listening who wants to dig deeper, definitely check out those hyperbaric medicine practice chapters or the IBUM database we mentioned. There's always more to learn.